thank you for the invitation. As one of the few non-oncologists here, I'm going to have a slightly different perspective on pancreaticobiliary cancers and try to take you through what the role of, I think, a real state-of-the-art endoscopic service can offer to your patients. So I don't have to tell this group that pancreas cancer is rapidly becoming a very significant disease that we will need to address in increasing numbers as the population ages. And at Sloan Kettering, our group really looks at pancreas cancer as more than just cancer. It is a whole spectrum from having to try to screen patients for this disease, if that is indeed possible, trying to interrupt carcinogenesis, dealing with invasive disease, which you're most familiar with, and then a large part of what we will be doing is palliating, because as you know, many of these patients will die of their disease and have symptoms caused by their disease, and what can we offer them? And we like to think we can play a role through all parts of this, from looking at things like a familial registry, looking at cyst fluid analysis and hopefully interrupting the transition of a mucinous cyst into cancer, biopsying invasive diseases, or potentially even playing a role now as a therapeutic adjuvant, as I'll show you, and finally a lot of endoscopic interventions in the palliative setting. So there are many potential pathways for pancreas cancer to develop. Panin is the most common. And unlike colon cancer, where we have a defined adenoma, adenocarcinoma sequence with a pre-malignant lesion that we can identify, we can remove very safely with a colonoscopy, here we don't have that. Panin is essentially invisible to the naked eye. You'd have to be looking pathologically, or at least with very high resolution pancreatoscopy. And the interventions that we have right now are not to reverse panin or remove panin. It's really just surgery. So that's a much bigger hurdle to overcome. So simply trying to extend the colonoscopy screening algorithm to pancreas cancer will not work. So we're looking for enriched populations. One of the most common ones you will, I'm sure, be asked by your patients is they have pancreas cancer. What should my brother, my sister, my child do? And unfortunately, pancreas cancer cannot be screened for as readily. So all of the screening, I believe, should be done in the context of a study, which is what we and many other large centers are doing, where we will bank blood and saliva, we'll assess the feasibility of screening and surveillance, collect various data on risk factors and environmental and lifestyle factors to try to learn something about this disease. So what we are including are patients with pancreatic ductal adenocarcinoma and a strong family history, at least 2 first-degree relatives, and then those with disease and an associated syndrome, such as BRCA, PALB2, Lynch syndrome, Peutz-Jeghers. These are all being accrued into our screening program, and we're offering screening with annual MRIs with EUS to follow any abnormal MRI finding. Currently, we have about 506 active high-risk family members undergoing screening. Earlier study by one of my colleagues showed that we had a yield of about 8.2%, which sounds high, but most of these were either mucinous lesions or precancerous lesions, some neuroendocrine tumor, things that didn't really benefit from early detection per se. Although very recently we had this case, which is really maybe our first successful screening case, where we had a 60-year-old asymptomatic relative with 2 first-degree relatives with pancreatic ductal adenocarcinoma, had a series of negative scans since 2010. In July of 2014, she had a normal gland, and in December of 2015, she had a small lesion found on EUS, needle positive for adenocarcinoma. And this patient went on to have a node-negative resection. It's also a critical resource not only for the patients, but for collaborative studies with our translational scientists. This was a study that was put together by Christine Acobuzzo, who looked at a variety of mutations in our familial pancreas cancer registry. And what we did, we were able to validate the known genes, but also had potential new genes that we've identified that they can then look for as to help try to understand some of the pathogenesis of this disease. The other major precursor lesions besides panin are the pancreatic cysts, the mucinous cysts, which I am sure in all of your hospitals are becoming more and more common. We are seeing more and more of these patients with pancreatic cysts, and as the numbers go up and the imaging gets better, the average size of these cysts decreases, so their significance is likely coming down, and what we're really looking for is sort of a needle in the haystack. Patients get very anxious about these lesions. They want to know what should be done, and really only a small minority of these patients will ever require any sort of significant intervention. In 2013, we looked at it, over 2,400 clinic visits at MSKCC were just for pancreatic cysts, so it's really a burden of disease. When we look at these cysts, we try to approach them by taking a history and their imaging. Certainly things like family history, BRCA will play a role in how aggressively we follow these. We'll try to analyze the cyst fluid and then to come up with an algorithm of either observation or management. Cystic lesions of the pancreas right now in determining whether something is mucinous or precancerous versus a serous or completely innocuous lesion. The best marker to date is CEA, but still the accuracy is only about 70 or 80%. But CEA doesn't discriminate the degree of dysplasia. So all it tells you is whether it's a mucinous cyst or not. It doesn't tell you whether it's a particularly high-risk mucinous lesion with high-grade dysplasia or one that can, with low or intermediate-grade dysplasia that can just be observed. When we look at our group of resected patients who've had high-risk lesions defined as high-grade dysplasia or carcinoma, like a small colloid carcinoma, or low-grade or moderate dysplasia in a low-risk group, we're trying to distinguish these because the high-risk patients are clearly the ones that would benefit for operative intervention. There is no endoscopic cyst ablation that's ready for prime time yet, so if you determine you have to do something about a cyst, you're generally talking about resection. Peter Allen in our group looked at several inflammatory markers, and IL-1B really looked to adequately distinguish these high-risk lesions, the ones that would warrant operative intervention compared to the low-risk lesions. This is now being validated in a much larger study, and we're hopeful that this will then become the real marker for mucinous lesions and trying to help us correctly identify those patients who will benefit from an invasive surgery. We've also looked at trying to combine this marker with many others as well as history to again try to figure out in 2017 who will benefit from surgery. And this was work primarily done by the group at Hopkins, and they were able to show that they could identify 91% of the patients who would have avoided surgery. In other words, the final pathology on their surgical specimen was either low-grade or moderate dysplasia, and they could have safely been observed for a period of time. So more commonly, what you guys are encountering are a solid pancreatic mass, and what the gastroenterologist can typically offer for you is a biopsy. But we're learning now that it's clearly not enough to just be able to say positive for adenocarcinoma or not. We really have to get enough tissue for you to do what you need to do, whether it be molecular pathology. At Sloan Kettering, it's the IMPACT panel, but all major centers have something similar. Whether you're trying to grow organelles or xenografts, you have to be able to work with your gastroenterologist and oncologist together so that they can get the adequate amount of tissue. Is a core biopsy necessary? Is a cell block adequate? All of these questions need to be addressed before the patient is on the table so you can provide adequate tissue for all of them. And we generally will not biopsy patients going directly to the OR, only if a negative biopsy would alter management. So some of these patients still at Sloan Kettering are not getting neoadjuvant therapy, and they will go directly to surgery without tissue biopsy. In terms of stenting, preoperatively, this is the landmark study from the New England Journal for a couple of years ago. We looked at 202 patients, found that those patients who got preoperative biliary stenting did worse. There are a lot of caveats to this study. It was in a modest range of elevated bilirubin, so anybody with a bilirubin of approximately 15 was excluded. The ERCP and drainage wasn't really left for very long. It was only for about a 4 to 6 week period. And it was a plastic stent with low ERCP success rates. So here, again, if somebody has a relatively low bilirubin, less than 14, and they're going directly to the operating room, it's probably best to go with sterile bile. However, if they have a high bilirubin, if there's going to be a prolonged time before they go to the OR to receive neoadjuvant therapy, if they have significant comorbidities, or if they have compromised renal function, we would definitely want to stent them. Also, if they have a right hepatic artery in the setting of jaundice, that hepatic artery will likely get sacrificed, and you want to make sure their liver function is improved prior to going to the OR. There had been a long battle about plastic versus metal stents. As you know, the plastic stents, while they don't create the inflammatory response that a metal stent does, they clog very quickly, and we've all had patients coming in with significant morbidity from repeated bouts of cholangitis from plastic stents. We looked at our ability to place a metal stent in all resectable patients, and as long as these metal stents are placed low enough so that there is sufficient common hepatic duct for your surgeon to resect, there is no increased risk of adverse effects in the perioperative period. So it is our practice for anybody with a malignant biliary stricture to place a metal stent, and really plastic stents have no place in this disease anymore, except for maybe clogged metal stents, putting more and more of these in. But the plastic stents don't have the necessary durability to get a patient through neoadjuvant therapy. They'll clog when a patient is on chemotherapy. They will get cholangitis and create significant morbidity. So we all favor the metal stents in all of these situations. So if you can aspirate a tumor to get tissue, can you inject something? And there were two early studies that showed we could safely do this. So the first thing was to put a fiducial an inert piece of gold, to allow better stereotactic radiation therapy. It allows for better respiratory gating. And it's sort of amazing that you can just go insert this through a non-sterile environment in the GI tract into a tumor. You get no infectious complications. These are very well tolerated. So this led to the idea of whether we can then use EUS as a platform to deliver local therapies. The first attempt at this was something called TNF-Arade, which was a replication-deficient adenovirus vector. And although there was very interesting preclinical data to show activity of this TNF-Arade, when this was combined with standard of care, there was no improvement of survival. But also, importantly, there were no real adverse effects. So again, you could go into the pancreatic tumor, you could inject a significant volume of material and not cause rip-roaring pancreatitis or problems like this. So it's led us to believe that if we have something that can overcome the stroma and has activity against the tumor, then potentially we can be an adjuvant to helping treat these patients. So the problem with local treatment, as you all know, is the microenvironment. It's a dense fibrotic stroma. It's resistant to diffusion. So if we were to just inject a liquid into the tumor, it really wouldn't go anywhere. So there is a company that has developed a biodegradable matrix that we can safely deliver, and it has a three-phase delivery where it immediately releases a lot of drug. It gets a very localized effect, which allows decreased pressure in that area of the tumor. So it creates a void where the next stage of drug delivery allows convection. And then finally, as the drug creates a greater void, you get diffusion and mixing. So they have developed a siRNA, a silencing RNA against KRAS, and it has been delivered in these small loaders that we can place directly into a tumor. And here we can get about a 1.4 centimeter area of cell destruction in a tumor safely without causing pancreatitis. So there was some promising animal data and very preliminary human data presented at GI ASCO last year, and now a multi-center trial with a very aggressive regimen of trying to put many of these loaders into locally advanced pancreas cancer is being developed by Aline O'Reilly and other colleagues. So we're hopeful that this will open shortly. The other area that your gastroenterologist will actually help you very frequently in pancreas cancer is management of complications. Over 80% of patients with pancreas cancer present with unresectable disease, and of the patients who get resected, the vast majority of them recur. And morbidity from pancreatic resection is over 30% with leaks that often require some sort of interventional therapy. Virtually all of these patients will require some sort of palliation, may it be biliary stenting, duodenal stenting, transluminal drainage to obviate the need for external drainage, celiac plexus neurolysis to help with chronic pain, and nutrition support. So our current approach is to place a stent either by a PTC or ERCP, but you all know very well that our stents leave a lot to be desired. They fail from tumor ingrowth, from overgrowth, from hypertrophy, and it results in cholangitis, typically on a Friday afternoon right after the patient has received chemotherapy. So what more can we do? And there is a clear clinical need to have some sort of more durable biliary palliation. And what we have looked at is this technique of delivering irreversible electroporation, which allows for rapid pulses of an external electrical field that changes the cell membrane. It causes the cell to die, but it does not destroy the stroma. It has several advantages because you can do it near the portal vein because there's no heat sink. This is not dependent on heat, such as RFA, or cold, like cryoablation. The problem was always that it required a positive and a negative electrode, hence you see these two prongs in here with a percutaneous approach for treating a tumor. We were able, with our engineers, to develop a catheter-based IRE probe that we were able to insert into the bile duct, into the pancreatic duct. And in preclinical models, this is a pig ERCP, and for any of you who are interested, pig ERCPs are exceedingly challenging because pigs will eat anything you leave them with, including their bedding. So if you plan on doing a pig ERCP, you have to take everything away from them so that when you go down in their stomach, their bedding is not sitting there. But the pig ERCP, you can see the probe positioned in the bile duct. We ablated 2 areas, and most importantly here, keep in mind there's no stent, there's no stricture, and most importantly, there's no leak. So we delivered this energy, we immediately shot a cholangiogram, and there's absolutely no leak, but we were able to get full thickness ablation of the bile duct wall. So this would tell us that we got a very good kill, very safely, similar to what we see in IRE and other areas. So we think that this is a very promising palliative approach, and we're looking to bring this to human trials in the palliative setting to help maintain stent patency. So hopefully in the future, we'll be able to provide a more durable palliation for your patients. The other more novel things that have been developed are transluminal drainage. This initially was developed for management of chronic pancreatitis and pseudocysts, but certainly we see pancreatic fluid collections after pancreatic surgery. We see acalculous cholecystitis from gallbladder obstruction, and these patients require cholecystostomy tubes. These external drains hurt quality of life. You get electrolyte derangements from losing a lot of bile. You get creation of pancreatic or biliary fistulas out to the skin. So it would be very, very appealing if we could drain these things transluminally into the stomach, and we can now do this quite safely. We can do this with postoperative fluid collections like you see here. We can do it with the gallbladder. We can do it with the bile duct as well. And if you looked at our comparison to percutaneous drainage compared to endoscopic drainage, it's very, very similar. And again, we have the inherent benefits of not having a percutaneous drain with all of the effects on quality of life and electrolyte derangements. This was an interesting case that one of my colleagues in medical oncology sent me with a large cystic tumor in the pancreas. The patient was incredibly symptomatic with extrinsic compression of their stomach. You could tell when they came in, their abdominal wall was deformed. And he asked if there was anything we could do. This was just a large cystic component of the tumor. You can see we did one procedure. We drained it transluminally into the stomach, and then we never changed these stents. We let him be. And you could see he got quite effective palliation until his disease progressed. For approximately 4 years of successful palliation, he was able to eat and drink. So I think this idea of draining things internally where the fluid's supposed to go anyway instead of out to the skin is really very, very appealing to us. So I think gastroenterologists have the opportunity to intervene clinically meaningful ways throughout the entire course of disease, from trying to prevent and identify patients at high risk for the disease all the way through palliation. I think our role treating active disease as an adjuvant using an EUS-based platform will be growing in the future. I think we can sample tissue all throughout disease, stages of disease progression, which I think will become more and more important as we are targeting therapies and having more personalized medicine. I think this application of this model provides substantial benefits for patient care, the primary oncologic services, as well as gastroenterologists. And I'll leave you with a picture my daughter sent me of now my favorite chicken finger that looks exactly like a pancreas.